So somebody put a really nice picture of a bunion and asked a few details about it, and it was too long an answer to type, so it's a shorter video to do instead. And just for clarity, this is a bunion. A bunion is an inflamed bursitis. People use bunion interchangeably for hallux adductor valgus, the deformity, or stiffness within the joint, which are of course different things. But here we are just talking about an actual real bunion, a inflamed bursitis on the side of the first MPJ. So a little bit about bursae, first of all. Bursae are naturally occurring structures. You get them throughout the body, and they come in 4 flavours. There are superficial or subcutaneous bursae, which are the ones just under the skin. There are submuscular, can't remember if they're called submuscular, but they're the ones that happen under muscles, which are between muscles and bony prominences. There are synovial bursae, which happen between a tendon or a ligament and a bony prominence. And there are the ones we're interested in, which are adventitious bursae, which are bursae you are not born with. These are the ones that form in response to trauma, generally from footwear. So in the foot, there is exactly one naturally occurring bursa. There is one bursa that you are born with, and it is the retrocalcaneal one. So you've got your heel bone coming down like this, you've got the Achilles tendon running up the leg like that, and between that Achilles tendon and the heel bone, to stop that sort of rubbing, there is a little bursa right there, retrocalcaneal bursa. That's what you're born with, but most people die with lots of bursae in their feet because, of course, our feet take a lot of punishment. Popular places to get them are obviously the big toe joint, the side of the little toe joint. It is possible to get them intermetatarsal. It is conceivably possible to get them under the heel. That is technically your policeman's heel, although there's some controversy there over whether that is a thing or not. And it is even conceivable to get them on the dorsum of an MPJ, particularly if you spend a lot of time kneeling. So obviously we're thinking about people who pray a lot, and sometimes people that do a lot of martial arts, because when you kneel in martial arts, Seiza position, you can actually push on the top of the joint. So sticking with the one on the side of the big toe joint, a normal, happy, healthy bursa forming in response to trauma is a good thing. It is there to protect you. Think of it as the body doing something to look after itself in much the same way as the skin thickening. It's meant to be there. And a normal, happy, healthy bursa is quite thin. It is formed of synovium, which is the membrane, and a tiny little bit of synovial fluid. Think of that as being like egg white, which sits between the 2 layers. So a bit like a bubble wrap envelope, you know, the bubble envelopes that have just a tiny bit of space in the middle with a little bit of a membrane either side. And they can be there, they're happy, they're good for you, they will help. Where it becomes a problem is where it becomes inflamed, and this is the itis bit of the bursitis. When they become inflamed, the synovium overproduces the fluid. So instead of being a nice sort of bubble wrap, bubble envelope type thing, it sort of expands and becomes more turgid, more fragile, more full. And that is a problem. That is painful, and it is less able to do its job to protect the deeper tissues. And that, of course, is what has obviously happened to this poor person. The problem at this point is the inflammation within the bursa. That's what we need to fix. Now, we cannot get rid of the bursa, short of a surgeon, and we probably don't want to get rid of the bursa because the bursa is doing a job. What we need to do is to make it not inflamed anymore. At the risk of sounding obvious, it became inflamed in response to trauma, so we need to reduce the trauma. And on the side of the joint like that, there is really effectively only one place that trauma is coming from, and that is footwear. Footwear, of course, is the shoes that the patient comes in to see you with, but also don't forget to look at the slippers, because if they're living at home, they probably spend more time in slippers than they do in shoes, and compression hosiery. Compression hosiery, particularly if there's a seam that runs across the joint, can actually trigger that sort of symptoms. So this is where your superb negotiating skills come into play, and you can explain to the patient why they have the problem, and if they wish to get rid of the problem, what they will need to change to get rid of it. Different tools you can use there are, if it's a leather shoe and the patient is particularly attached to them, maybe taking them to a cobbler's to get that bit stretched, or if you've got a shoe stretcher in your clinic, it's not a terrible thing to have. Just bung the shoes on there whilst you're treating their feet, half an hour, probably not a bad idea. Fabric uppers. There's a lot of shoes now, things like Skechers, some trainers have fabric uppers, which of course will conform better around it. Cozy Feet, and I think Cotters do a neoprene uppered shoe, which is a bit more substantial, better for winter. If they are wearing compression hosiery, make sure the seam is not across there, and maybe see if there is anything that can be done to change that. And at a pinch you can try gel pads. You can get gel pads of various designs to sit over the top of it. It doesn't protect it from pressure, but it does protect it somewhat from friction, because the friction, the movement happens in the gel, not in the foot. That's very much a second best approach, but it's worth a try in extremis. And of course, the thing we have to be particularly careful of is that there are no breaks in the skin. This one looks all nice and puddingy, but if you get a corn there or a rub or a blister or something like that, you've got a portal for infection, and then you can end up with septic bursitis, which is something that you do not want. In that situation, the bursa, instead of being full of nice slimy egg whitey synovial fluid, fills up with pus, which is not as effective at that. And of course, then you are in real problems, and we are probably looking at surgical intervention. So just to recap, a bunion is an inflamed bursitis on the first MPJ. Bursae occur throughout the body. Most of them in your feet are adventitious, which means they form in response to trauma, and reducing that trauma is the way to reduce the inflammation when there is an inflamed bursitis. Hope that helps.